Morning, everyone. Thanks for joining us today. And looking forward to this conversation on today's webinar as part of the Knockout Opioid Abuse Learning series, When Addiction and Mental Health Collide. So today's webinar is designated for 1 AMA PRA Category 1 credit, 1 ANCC contact hour, 1 ACPE contact hour, 1 AAPA Category 1 CME credit, and 1 ADA CERP continuing education credit by the American Academy of CME Inc. And for any pharmacists claiming credit, please note that your credit will be uploaded to CPE Monitor within 30 days. This webinar has also been approved by NJOEMS for 1 EMT elective CEU. Our PA planner, Dean Barone, discloses that he serves on the Speakers Bureau of Ethicon and Johnson & Johnson, and all other faculty and planners have nothing to disclose. Today's webinar is jointly provided by the Partnership for a Drug-Free New Jersey and the American Academy of CME Inc. and is being held in collaboration with NJ Cares and the New Jersey Office of the Attorney General and the Opioid Education Foundation of America. And I once again thank them for their partnership, support, and collaboration on today's learning activity and throughout this year-long learning series. I'm so pleased to welcome today's expert speakers. We have Dr. Tim Vermillion, a behavioral health officer with over 24 years of military experience. Tim is a doctor of social work and has a master of social work, along with a master of education in adult and continuing education. And for those of you who've been in the prevention and treatment field throughout the years, you may remember Tim from back when he was with the New Jersey National Guard and helped out at the DEA with the demand reduction unit. So we're glad to see you again, Tim. We have Tiffany Wilson, who's the Senior Counsel and Director of the New Jersey Office of Alternative and Community Responses. And we have Jill Schlossberg, Director of Peer Support Services for Mental Health Association of New Jersey. And Jill is a licensed professional counselor with 17 years of clinical experience in both mental health and addiction-based therapies. And I thank all of our expert speakers for being with us today. I think we're going to have a really good and necessary conversation. And Tim, I'm going to turn the presentation over to you.
Hello, everybody. I'm glad to be here. Again, I'm Tim Vermillion. So Tim is something I'll answer to. So that's well, we'll start. So in terms of our presentation today, or my presentation today, it's mostly going to be centering around opioid use and opioid misuse as part of the result of prescription meds and whatnot. We do have the best heroin in New Jersey because we are so close to the ports, right? So by the time the heroin gets through the port of Newark, right, it's kind of like uncut, pure, and then it slowly gets cut as it goes down. But now we've also added fentanyl to the mix. So our opioid strength is pretty high in New Jersey. And as we see people that go from using medications, opioid medications for physical issues and mental health issues, and gradually find themselves using the more illicit drugs. So if we can go ahead to the next slide. And this is information from 2020, right? Apparently on this website, it's the last year that we have the information available. And we can see on the top right there, what we're looking at as far as the opioid overdose deaths, which is over 3,000, almost 4,000 deaths for all opioids together. We can also look at it as broken down by age, group, and sex, and between 25 and 54 are our biggest populations of overdose deaths. We can also look in the middle there by race and see as far as how the overdoses are falling out by race, and then finally by county. And it's a good idea to kind of look at the counties and kind of see where you are. So if you want to think about the amount of overdose deaths in your county, as we go through this presentation, there might be some way of thinking about it, what you can do in order to try and reduce those overdose deaths in the practices that you work in. When I'm thinking about this, I also think about somebody that I actually knew from college. His name is Michael, a very, very good friend. Met his mother, lovely person. And Michael, when I met him, was already on Suboxone at 23 years old. So he was already on a medication that is a combination of as a narcotic, combination of bupropion, can't even say the word, buprenorphine and naloxone. And that's a medication that is actually used for opioid addiction. So he's already had that opioid addiction. He ended up in a car accident and had some chronic pain from that car accident. And so that led to him being prescribed an opiate. And as things happen, he got addicted to it. Next slide, please. So in our percentages there, we can see that in the United States, 64.3% of adults with opioid use disorder suffer from a current comorbid mental illness. And that's pretty high, right? That people can have both comorbid mental illness and an opioid addiction. And so this starts to muddy up the picture a bit because as the things happen, as you're starting to have that chronic pain, it's not just that you had a mental health concern to begin with, but now that you have chronic pain or some other issue, perhaps that's going to cause some mental health concerns, some adjustment disorders, maybe start to stimulate your a dormant major depressive episode or something like a bipolar episode or something like that. Only around 1/4 of adults with concurrent opioid use disorder and acute mental illness receive treatment for both problems. So of that 64%, only 1/4 of those actually receive the treatment for both of those things. When I met Michael, my friend Michael, he did not do any therapy, right? So that is an important piece to think about when you're thinking about the whole idea of using a medication for opioid use is this person in therapy as well for a mental health concern? And he did have a mental health concern, right? He did have depression. Would you please go to the next slide? So sometimes I ask people, what are the reasons why people might use an opioid? And so we have a bunch of different reasons here. And chronic pain, I put up on the top of the list because it's something personal to me. I mean, I know a lot of people have chronic pain, but Michael had chronic pain, and that was how he got hooked onto that medication. So the doctor prescribed him the medication, and he kind of fell into becoming addicted to it. And up until about a week ago, I had the a bottle from dental work. I had a bottle of codeine with that one, the Tylenol with codeine, in my drawer. And I was thinking about it because I have other medications in there, and I started to wonder, like, did I make a mistake? Like taking a pill, I took the wrong pill. Like, I started to think about that because for me, who's still in the military, it would also be an issue, right? Because the military has it. So if you are found to have opiates in your urine when you do a drug test within 6 months, and you don't have any prescription that is updated within that 6 months, then you can get kicked out, because of having that opioid in your system without having it been prescribed in the last 6 months. So I got rid of it immediately thinking about that. But in another way of thinking, I started to think about how how other people seeing that codeine in there can just be like, oh, I'm having pain today, or I'm not feeling well today, from whatever reason. And like, that'll probably help me for that moment, and start taking those medications and using them for things that they weren't originally meant to be used for. So we do have chronic pain as one of the main reasons, top reasons that I have on here for people that keep using that medication. We also have major depressive episodes. And again, if you have that bottle sitting inside of your drawer and you take and you're like, I know that makes me feel better, right? And you take one of those pills, why not take it the next day, or, whenever you start to feel bad? So it starts to be used as a self-medication, right? So that is one of the reasons. People also use it when they're feeling suicidal to feel better, and it does make you feel better. I mean, that's why people use it. Of course, we do know that when you take it, it causes addiction. It causes your body to become dependent on it, and also a psychological addiction saying, hey, when I use this, I know I feel good. So this is a crutch that I can use whenever necessary. I did put other mental health concerns in here because it's not just major depressive episodes, although that's one of the major ones that have been studied in the research. So I did put that on this row. Being lonely, social isolation, basically anything on the bottom here in quotes, anything that helps people cope with negative feelings, or whenever they need to feel good, right? They might need to use that. And my friend Michael, he would often have that issue with his major depressive episode, that he would also feel lonely. He wasn't working at the time. He was living with his mother. And so he had a lot of issues come up. Unfortunately, he did end up overdosing. So, it's a really a strong personal story for me, and it is something that I keep in the back of my mind, and one of the reasons why I'm so interested in trying to kind of work with opioids addiction and people with mental health concerns. My biggest field of work is trauma and PTSD, right? So that's what I do. I actually work in the VA now as a therapist in a BHIP, which is basically a behavioral health integrated program, where it's almost like a integrated pack, where you have a nurse, a doctor, a pharmacist, everybody, a peer specialist, everybody in the same place, so that we can work as a team, right? And that seems to be one of the best ways to work with all different populations, including those that abuse substances. I'll go ahead and change the slide. Interestingly enough, when we talk about trauma and PTSD, it has been shown in some research that PTSD does something to the brain, where all of a sudden there has some issue with the endogenous opioid system, or maybe even it's the lack of cortisol that might come from having PTSD. But in any case, there's an effect where in the VA, people with PTSD tend to become more addicted to, or more often addicted to, the opioids, right? So we are aware of that, and we try to figure out how to best deal with that issue. All right, so this is probably true not just in the VA. They don't have they don't hold a monopoly on PTSD, and so this is also something to consider when you have people going through other traumas. And there's a lot of them out there. I know that we just had the bridge collapse in Baltimore, which is a horrible thing. Go ahead and hit the slide. So here are some treatment recommendations, right? So cognitive therapy has been around for a long time. It started out with cognitive therapy for alcohol abuse, and then it was adjusted to make cognitive therapy for substance abuse. But there's some things that we would have to kind of twerk in there to pull around, because people that are heavy into opioids, they need to get their lives together, and they might not be able to sit there and do all the homework that's required. But the engagement of in cognitive therapy can be one of the most effective components. Also, with these substance abuse related cognitive therapies, they usually incorporate motivational interviewing, which is something that you could often use in your own practices to get practice in doing motivational interviewing, to get people from where they are. Maybe they're, thinking about getting help, to getting help, and then to following through with help. There's also CBT for treatment seeking, which is only like a one episode cognitive therapy treatment. And you can use that again to help people get into treatment, from doing your primary care session into moving into getting a substance abuse treatment as well. Some other exercises that you can do is the mindfulness exercises, which we all kind of know about. Deep breathing, mindfulness-based stress reduction. There's tons of them out there at this point. Yoga is also a great mindfulness body-related type of thing that you can do. In the VA, we also have STAR program, all these different substance abuse programs. Some of them are abstinence-based, and some of them aren't, right? So we do have this type of non-op abstinence-based one, which is the COPE, right? So it's concurrent treatment of the substance abuse disorder and prolonged exposure. Long ago, not too long ago, I guess, but long ago, we would say that we want the people to get through the substance abuse before we ever work on trauma. Now we're working on them both at the same time, finding that the trauma is stimulates your stuff, your drug use. Something about medication-assisted therapy, right? So they do find that once people are getting on Suboxone or some other medication for their help in their opiate use, It's good if you're going to stop that at some point, because people do try to stop that after a while, to watch them for 2 years. Most studies are only watch 1 year, right? So we want them to watch for about 2 years. Okay. Yeah, I do see the questions, but we'll wait for them during the panel, if that's okay with everybody else. And then, of course, people would require case management, especially if they've lost a lot of their livelihood due to their substance abuse issues. Last slide. So other considerations, right? Cost, stigma, and distance and availability. And this is where you come in. And I know that one of our other panelists are really going to get into this integrated stuff, the collaborative model, so I'm not going to go into it too much. But as far as people coming in with stigma, they don't want to be seen going to a drug abuse clinic or something like that. So you are their first foot in the door. So if you ask the appropriate questions, and you can even prescribe, some of the doctors anyway, you can even prescribe some medications that can get them started in their mental health journey. So this is one of those things that we want to kind of really push, is the integrated type of setting, where you might have some good referrals for mental health, understand the medications for mental health concerns, and some motivational interviewing, and the cognitive behavioral therapy for treatment-seeking individuals, which again is about one session. The telehealth thing, again, when we're talking about distance, telehealth is fantastic. So I never want to discount that. People usually need to be seen like once in person, but after that, if they don't feel like they can come to the session, telehealth is awesome. I'm in New Jersey. I work in California, right? So all my work is for the VA is telehealth. I do substance abuse stuff. I do trauma work. I can do everything. Do almost everything. Lots of suicidal clients as well. So please use telehealth. And next session. All right. So again, we're going to save the questions for the back of during the panel, and I look forward to hearing all of your good questions. Here are some resources.
Thanks for your great and insightful presentation, and thanks for your service. But we appreciate you being on. And as you mentioned, yes, we're going to hold all questions until all of the panelists present, and then we'll come back and be able to get to all of those questions. So thanks, and continue to put those into the chat. I'm going to turn the presentation over to Tiffany now. Tiffany, welcome.
Thanks, Angela. So as mentioned, I am Tiffany Wilson. I am the director of the Office of Alternative and Community Responses at the Office of the Attorney General. Our office has just been formally launched and has many aspects to it, but generally deals with the intersection between law enforcement and substance use disorder, and law enforcement and mental health concerns, and where those two areas often intersect. And so today I'm going to talk about our Arrive Together program. It was the first program as part of the Office of Alternative and Community Responses, and is a mental health and law enforcement collaboration in responding to individuals who have reached out to 911 or to law enforcement and are experiencing a mental health crisis or emergency, or are requiring mental health help. So we can go to the next slide. So as you can see from the video, Arrive began in 2020. It was a result of looking at law enforcement data. So law enforcement data showed us that the number of individuals who were involved in fatal police encounters that also had mental health or substance abuse issues, the percentage was just way too high. And so we were looking at that data and trying to come up with solutions for decreasing that number and that percentage. So in collaboration with the Department of Human Services in 2020 and community stakeholders around the state, the Attorney General's office developed a co-response program utilizing the state police in Cumberland County and in partnership with the Cumberland County Prosecutor's Office, which partnered the mental health screeners in Cumberland County with state police. For those of you who don't know, the Attorney General, among the many things that he oversees the state police. So this was a relatively easy pilot in terms of getting buy-in, because he can obviously just order the state police to participate in this program. And we had a really great partner down in Cumberland County with the Department of Human Services, as well as with the Cumberland County Prosecutor's Office. So that began as a co-response program. We relatively quickly spread to Elizabeth, so from Union County, where I actually come from and where I was an assistant prosecutor. And in Union County, we really tried to determine if this model would work when the Attorney General's office didn't control the police departments involved. And so Elizabeth and Elizabeth and Linden were the next departments to join and to try this as a municipal police department partnership. Atlantic City was next, where they utilized telehealth as their pilot model. Next slide. So in 2023, following the success of our co-response and telehealth models, and again, receiving input from the community at large, as well as the community of law enforcement and mental health providers, to determine if the pilots that we were launching could work everywhere. And what we found was that there was also a need identified that was for follow-up. So in some locations, so if you were in Union County, for instance, just because of the dense population, it could take quite a long time for screeners to get to the furthest location in the county. And so what they were experiencing was increased escalation when waiting for screening or screeners to be able to get there and hopefully be able to de-escalate a situation. In some counties, that wasn't a problem. They could get there relatively in short order. And it wasn't the escalation, it was the follow-up that was necessary. And so the next model that launched was our follow-up model. Next slide. So utilizing basically those three models, plus an addition, because again, in meeting with our communities and all of our community partners, one of the things that we found was that in certain counties, the issue was that our law enforcement officers could not travel with our mental health screeners. So the first pilot was co-response. It was a law enforcement officer with screener in car, and they just didn't have that capacity. And so, but what they did have the capacity for, because our screeners had the ability, was they could meet law enforcement on scene. So we also had a close in time follow-up model where law enforcement's on scene and mental health provider can join law enforcement on scene right in the same moment. In our follow-up model, it was more of a referral. It was law enforcement identified somebody and then referred that individual to a trusted mental health partner, all of them resources that law enforcement could have. So with all of those models at the end of 2023, just shy of 2 years from the very first launch in Cumberland County, there's an Arrive model in every county in Union County, every county in the state. And in Union County, Kane University became the first institution of higher learning to participate in Arrive, both as a partner with their surrounding law enforcement agencies, responding to calls throughout that particular community, but also in partnership on campus. So utilizing the mental health services that are on campus for that community's specific needs. Next slide. And really this all stemmed from the fact of a recognition that for a long time, we really asked law enforcement really to undertake way too much. They've become marriage counselors, addiction specialists, social workers, and really the community has expected them to be able to respond to that. And that our system has been structured so that an armed police officer is responding to the same armed police officer that's responding to a robbery is also the same person who is responding to a behavioral health or mental health or substance use disorder emergency as well. And then we wonder why there are bad outcomes. And so we really just wanted to give individuals, our law enforcement officers, an additional resource to respond to what they were actually seeing. And we know that law enforcement has also been on the front lines of the opioid epidemic, both in trying to curb it as well as trying to address it, because they are really the first to see it. So next slide. So what we were trying to fix. So again, it came from data from law enforcement. So really what we were trying to fix is we wanted to reduce uses of force. We wanted to reduce fatal police encounters, particularly those that began as a call for help, particularly a call for help that was medical in nature. And so it was as simple as that. We wanted to reduce those numbers, but we also wanted to alleviate the burdens that law enforcement was experiencing when they are responding to these calls, or they were just feeling under-equipped to meaningfully respond. I can't tell you the number of times that after Arrive launched where I ran into a police officer, maybe at the local Starbucks or while walking through the courthouse, where they have said, "It's about time. Thank you so much for getting us these resources. We've needed these for so long." And that really was what we were trying to do. We also wanted to reduce the opportunities for unacceptable outcomes occurring. So we wanted to provide the right resources. We wanted to provide them in a timely fashion. And we wanted to decrease the anxiety of the person who was needing assistance by putting them in a situation where they had to wait to get the appropriate help. Next slide. And so what we're seeing safer outcomes for our most vulnerable residents by providing a mental health specialist rather than an officer who can address behavioral health concerns. So in our co-response and close follow-up models, when officer and mental health specialist arrive together as part of the Arrive team, the mental health specialist is the one who takes the lead in the entire interaction. And in doing that, we've actually increased the amount of safe outcomes that we are experiencing. In addition, we are seeing an increased utilization of mental health resources. So we know that sometimes individuals don't want law enforcement. They don't want to interact with law enforcement. We've also found that they also sometimes don't want to interact with mental health professionals. Maybe that person has taken them to screening or involuntarily committed that person before. And so the concern is with the mental health partner. And so because these Arrive teams are in fact teams, they can work with that. So if they notice that the anxiety is towards the mental health provider, then the law enforcement officer steps in, but it's a CIT, crisis intervention team, trained law enforcement officer who is working with that individual. And so they literally play as a team to try to get this person the best help that they can and to encourage them to interact with them. Next slide. The other thing that we've seen from Arrive, it actually keeps residents in the community. We know that in the past, law enforcement's answer was really, well, I'm just going to call screening, or I've observed behavior that allows me as a law enforcement officer to take somebody involuntarily to screening, so that is what I'm going to do. But what we have found with the Arrive teams is that the mental health professional has been able to de-escalate the situation, help to stabilize, help to provide resources, and to assure that follow-up is coming. And because of that, everybody has felt comfortable leaving that individual in the community, understanding that there are going to be follow-up resources. So when we have found that when Arrive teams are present, we are decreasing the number of involuntary transports to a screening service. And it's also improving trust between law enforcement and community. And just a quick story, we recently have had cases where an individual has been taken to the hospital and has gone through either mental health or substance use disorder inpatient treatment. And that person, before being discharged, has called the Arrive teams and said things like, I need help. Can you help me? I know that there is alcohol still in my home, and I don't want it to be there when I go home because I've just gone through this treatment and I'm really committed to my sobriety. And I don't want that in. And the Arrive teams have gone on their off hours to help clean out that home and to help assure the individual that they will have support when they return back to their home. Next slide. And the beauty of Arrive, at least from our perspective, is that it uses existing resources. We are not pretending that law enforcement are mental health or substance use disorder professionals. It's exactly what we're trying to avoid law enforcement being. And so what we do is we use existing resources. We're not creating new programs. We're using the programs that are in the community, using programs that maybe some of these individuals have interacted with before or that they will be interacting with in the future. It doesn't require that the individual actually know that Arrive exists. Do we want people to know Arrive exists? Of course we do. That's the best case scenario, that they know when they call the police that they are going to get a response that isn't their worst case scenario of a police response. But if they don't know it exists, they can still get the service because either the dispatcher will call an Arrive team or the law enforcement first responder who goes to the scene will recognize that it's a mental health emergency and would really benefit from an Arrive response. And they call in the Arrive team. That officer goes back to regular patrol and the Arrive team takes over. So there doesn't need to be confusion. Nobody doesn't not get the program because they didn't ask for Arrive. And we actually think that's a great benefit because it just decreases confusion in the community. It provides valuable on-the-job training for mental health and law enforcement. Both partners and an Arrive team have said to us, it's the best training I've ever had. I've learned so much just sitting in the car with or spending so much time with mental health or with law enforcement. I now understand blank, and they've told us it's the best training. And in almost all situations, our mental health providers, in addition to working with their assigned Arrive partner for the day, have also gone back to the police station and done like mini trainings over lunch or over coffee with other law enforcement officers who might not be on the Arrive team, just to teach them how the system works and what they can be looking for, or why some of the frustrations that law enforcement sees related to the revolving door, how those might be systemic, and maybe how they can work together to solve some of those systemic issues in their community. It's customized specifically to the community. So every community's Arrive program looks a little bit different based on resources, based on need, based on the community's appetite for certain things. Some communities just aren't ready for co-response right now, and that's okay. They can do follow-up. What we find is that the communities that do follow-up eventually say, oh, we can handle co-response. And then that happens. And the communities that do co-response say, we really could benefit from follow-up. And we're seeing a merging of models, but it's their own choice. So there's also community buy-in, and it leverages and encourages and leverages more comprehensive programs. So we're just bringing the people to the table. And if they want to expand their program or build upon it, that framework already exists. Next slide. So Brookings Institution at the beginning of Arrive did a study of the original pilots with really positive outcomes. And I would just point you to that study. But we saw a reduce in force, a reduce in arrests, a reduce in racial disparity. So all of places that we would love to see reductions, we are definitely seeing it with Arrive. And our current data also supports that findings. And we do have an updated Arrive dashboard that can be found on the Attorney General's website. Next slide. And so just some outcomes, and these I'll actually update them for you in real time. So we actually have had over 2,800 Arrive interactions at this point. We're in all 21 counties. We've had 0 arrests related to the Arrive interaction by the Arrive teams. That's not to say that somebody who had an outstanding warrant didn't get arrested, but what we aren't seeing is an aggravated assault on police officer that person got arrested. Instead, that person got help. We've had 0 injuries, and we've had 0 uses of force beyond the amount of force necessary to effectuate an involuntary transport consistent with the screening law or at the direction of a mental health screener. Next slide. And as it relates to substance abuse disorder, Tim's already talked about it, and I think Jill will as well, but we all know that people with mental illness are more likely to experience a substance use disorder than those not affected by a mental illness. So when our Arrive teams are responding to what came in as a potential mental health call, they are often finding that it is in fact substance abuse related, or our follow-up teams are finding that is what is in fact happening. Next slide. So for purposes of Arrive, it did begin as a mental health program, and our partner is mental health, is a mental health related partner, though most of them are, most if not all, are trained in co-occurrence or work for an agency that provides co-occurring services. What we are seeing in our numbers is what the call comes in as is only 7 to 9% of Arrive calls are coming in as being flagged as substance abuse related. So that number is really low, which is, again, we were asking law enforcement to figure it out. You go to a location and figure out what it is, and their go-to we found was mental health. But what we know is that's not actually true. So again, our incoming data shows that the call came in, only 7 to 9% came in related to substance use. Next slide. But the beauty of it is that with our mental health partner, the mental health partner can assist law enforcement in gathering the necessary information, assist in identifying the right diagnosis, and assist in identifying the right resources, and to help the individual navigate the system, which we know is a huge barrier in many of these cases, or for many of these individuals, and it provides follow-up. So as it relates to follow-up, so when 7 to 9% come in as substance abuse, what the follow-up teams are finding is that it's actually closer to 20 to 30% of the individuals that Arrive teams are interacting with come in as a primary substance use disorder, and 45 to 55% of them are primary co-occurring. And before, we were just asking law enforcement to guess and then to make the right referrals. Next slide. So again, the majority, if not all, of our Arrive mental health partners are trained in co-occurring disorders or work for or partner with agencies that are, so that they are able to seamlessly, warmly hand off individuals to, or make referrals to the right and most appropriate resource. Next slide. So just a quick example of a mental health call or an Arrive call that had co-occurring implications, and why it was important, why we think it's really important to have our mental health partners on scene as close in time as possible. So we had an individual who was the third time that they were called to this location. The third time that the mental health partner was called to the location, the law enforcement had been called multiple times. At all times, the calls came in as somebody was having a mental health emergency. They were seen at the time, and they went through the normal process. So sometimes they left in the community, sometimes taken into the screening center. On this particular occasion, because the Arrive teams were there and could get there relatively closely, they quickly were able to de-escalate the situation, and the team was able to have a more in-depth conversation with the person in closer to real time, and an in-depth conversation with the family. What they came to find out was that this person who was experiencing paranoia and was majorly depressed actually had an opioid addiction, and suffered from an opioid use disorder, which the family knew. The person was utilizing Suboxone at the time. And what was actually happening was the family was not supportive of the Suboxone use, and so was titrating the individual off of Suboxone without medical assistance. And so what the person was actually experiencing was withdrawal. But in all other interactions, nobody was able to identify that. But because the team was there, had time, got there relatively close in time, they recognized what was happening. They got the appropriate medical treatment. They built trust with this individual. And when the individual was eventually released from the hospital, for the very first time, the individual participated in outpatient treatment. And this was somebody who had been interacted with both by medical professionals and law enforcement before that. And we do believe that that's because Arrive can get there quickly and can build that trust and has time to talk to family and others who might have collateral information. Next slide. And so our mental health providers are finding that due to a lack of escalation, faster de-escalation in our co-response programs and close follow-up models. And we also have a built-in 30-day follow-up. So all mental health providers are required to follow up with the individual 30 days later. They are able to build rapport with the family and the consumer and provide education. And they also report anecdotally that they have more time for more consistent screening to determine new and continued or worsening substance use or the identification of substance use where that identification had not been made before. Next slide. It also allows individuals to remain in the community and provide education. So our teams provide education related to harm reduction strategies, medically assisted treatment. They provide education related to naloxone, as well as the locations of our naloxone 365 locations. So pharmacies that are providing naloxone to the community, as well as other programs within the Office of the Attorney General and in their community itself, because again, community specific. Next. And that's it. Thank you so much.
Thanks, Tiffany. Great information. Appreciate you sharing on the Arrive program with us. Jill, I'm going to now turn the presentation over to you.
Oh, thank you so much to everyone. And thank you so much to Tiffany and Tim. You guys gave some great information. I feel like I should be done in like 30 seconds. So I'm going to discuss the impact of opioid use and mental health. Next slide, please. So when we look at the prevalence of co-occurring disorders, the co-occurrence of opioid use disorder and mental health conditions is alarmingly high, with individuals often grappling with both challenges simultaneously. So according to SAMHSA 2008 National Drug Survey on Drug Use and Health, 19.3 million adults who suffered from substance use disorder in 2018, out of those 9.2 million also suffered from a co-occurring mental health illness. The interplay between opioid use and mental health manifests in complex symptomology, posing significant challenges for diagnosis and treatment. I always like to call it, having worked in the treatment field, a play on the chicken or the egg. So when you're meeting someone and you're working with them, which came first? Was their mental health issues the primary diagnosis, or was in fact their substance use? But when we look at certain risk factors, such as genetic predisposition, trauma, and chronic stress, they contribute to a higher vulnerability to develop both opioid use disorder and mental health conditions. So accepted research is showing now that some people have vulnerabilities to addiction, and what's been established is this 3-factor standard for vulnerability, which I absolutely love. And it's this triangulation of genetic factors, environmental factors, and repeated exposure to drug use. It's also encompassing both physiological and biological components. So when we look at the genetic factors, research in neurobiology and pathology of the nervous system of addictions points to genetics as a major contributing factor to addiction vulnerability. So 40 to 60% of all those addicted have some genetic factors that place them at higher risks. Our genetics play a role in our personality, meaning the potential for the reward seeking and response to stress may lead to increased vulnerability. When we're looking at socioeconomical issues, what is someone's socioeconomic status? Are they in a low, middle, or high socioeconomic status? As Tim pointed out, what's the access to resources? What is available in their area? Are there wellness centers, recovery centers, mental health and addiction services? Or may they have to travel? I know a lot of times there is minimal programs unfortunately, in the southern part of New Jersey. So we find that a lot of people from southern counties are coming to more of the northern region. But what does that look like as far as different issues that they might be facing? What are their familial relationships like? What are the dynamics in the home? Is it a 2-parent household? Are they witnessing some type of domestic violence? Do they have access to substances? So do parents or family members use drugs? According to the Office of Human Services, between 2015 and 2019, over 31,000 children lived with a parent who misused substance in the state of New Jersey. Do they experience chronic stress? Is there physical, sexual, and some type of emotional abuse that may be going on in the home? Next slide, please. So what are the different treatment approaches to opioid use disorder? I felt like I could have probably spent an hour just on this. Next slide. So I feel that in my clinical approach, the best that we are seeing is with the collaborative care model. So the collaborative care model is an evidence-based model, and it is led by a primary care provider or PCP and includes behavioral health managers, psychiatrists, and frequently other mental health professionals, all empowering to work at the top of their license. And this is what's really important. So a lot of us in the field always feel that it is on the client or the participant to hold the most accountability. But with the collaborative care model, everyone is held accountable, not only the client, but everyone on their care team. And there are 5 goals of the collaborative care model. So those five goals are that a patient-centered care team. So primary care and behavioral health providers collaborate effectively using shared care plans that incorporate patient goals. The ability to get both physical and mental health care at a familiar location is comfortable to patients and reduces duplicate assessments. It increased patients' engagement, oftentimes resulting in better healthcare experiences and improved patient outcomes, right? If I know that I am the let's say it, I am the primary person in my care, that not only holds me accountable, but it gives me autonomy and makes me feel like I have strength and that I am actually a part of something. When working in treatment and working with a lot of mental health professionals, I found that the client has very little ability to speak on what's going on with their care, right? We are the professionals, we know what they need. This person, is coming to us for a service. So do they really have any say-so in their care? But with the collaborative care model, they do have a say-so, and it's very important that they do. The second goal is population-based care. So the care team shares a defined group of patients tracked in a registry to ensure no one falls through the cracks, because that's another thing, unfortunately, that happens. Practices track and reach out to patients who are not improving, and mental health specialists provide caseload-focused consultation, not just ad hoc advice. And again, this is so important because we've seen so many people who unfortunately fall through the cracks. The third goal is measurement-based treatment to target. So each patient's treatment plan clearly articulates personal goals and clinical outcomes. They're routinely measured by evidence-based tools. Treatments are actively changed if patients are not showing improvement as expected until the clinical goals are achieved. The fourth goal is evidence-based care. So patients are often, offered treatments with credible research evidence to support their efficacy in treating the target condition. So the collaborative care model itself has a substantial evidence base for its effectiveness, one of the few integrated care models that does. And 5, which is the accountability of care. Providers are accountable and reimbursed for quality care and clinical outcomes, not just the volume of care provided, which is something that is so nice to hear. When you're looking at this, it's not a numbers-based approach, but really a humanistic approach, which is so important when you're dealing with clients who are suffering with mental health and substance use issues. Next slide, please. So when we look at also, like we've discussed, allocation of resources is another big issue that we are seeing. So are all populations afforded the same resources when it comes to accessing services? Does someone who has really good health insurance, are they provided with the same type of services as someone who may only have a state-based insurance? And like Tim spoke about, we do have some barriers to receiving services. Language is a huge barrier. Do we have people on staff who speak the language of someone who is coming in? Or do we have to utilize services like a language line? I had someone call me recently who was looking for someone who spoke, I want to say, spoke Egyptian because they had refugees who had come over to their site who needed someone who spoke not Egyptian, who spoke Arabic, excuse me. And I unfortunately did not know anyone, so we kind of put our heads together and looked at what kind of resources were available to this person so they could get effective care. What does transportation look like? I live in Hudson County and I'm very lucky because I can walk right out of my apartment and I can have the ability to get on a bus. I can call an Uber. I can do all those things. But if I'm living in a program where transportation might be limited, what does that look like for me as far as accessing services? And I also love what Tim said, utilizing telehealth by all means possible, but sometimes we want to be able to see that, I don't want to say face-to-face interaction, but that, I guess, whole body interaction. What are the quality of services available? What are the hours of services? Do programs offer nighttime and weekend hours? And then we look at stigma, which is a huge one, both internal and external. So I know for myself, working with people who have mental health issues and substance use issues, that's a very big one for why people have limited ability to want to come into treatment and to want to seek services, because they have their own internal stigma about, is someone going to say that I'm crazy? Is someone going to think that there's something wrong with me because I'm going to see a therapist? And how is therapy and treatment services and addiction services viewed by, let's say, things like familial relationships or even culturally? Next slide, please. So then we look at prevention strategies. Next slide, please. So I can speak for myself. When I was in school and I was young, I suffered with a lot of anxiety, and we did not have any type of integrated school-based models that helped students regulate their own emotions. So it was kind of like grin and bear it. I can remember being dragged into class, what I assume at the age of 8 years old was a panic attack, and basically being told that I had to deal with it. I had to deal with my behavior and there was nothing that anyone could do. And also there's a stigma that gets attached when you have to go see the guidance counselor. It doesn't look good for you. People are talking about you. So integrative school-based models are so important when dealing with mental health issues and allowing children to have the ability to talk about what's on their mind and what's going on with them. So part of the Path to PACS program was implemented. It's an integrative intervention that was developed through a collaboration of the Johns Hopkins Center for Prevention and Early Intervention, the Pennsylvania State University Prevention Research Center, and the Paxis Institute. So what the Path to PACS does is actually, it is part of the curriculum for all students. So it is not just seen as, oh, this is something that the bad kids have to do. It is implemented as part of the curriculum. So teachers, school counselors, they are all trained in this model. It covers all those involved, like I said, of students and faculty. And again, it's a collaboration. It is curriculum based and it utilizes children's behavior as well as teacher management styles, which is so important. So the goal of integration was to create a more effective prevention intervention that aims to impact a range of risk and protective factors for aggressive and disruptive behavior problems by targeting teachers' classroom management style, as well as children's social emotional skills. So the process of integration and final model were very important when looking at this. So PACS, which stands for Peace, Productivity, Health, and Happiness. Again, it's a preventative program that uses strategies for children to manage their feelings and behaviors, which is important. And it starts at kindergarten. So we are teaching children how to regulate their emotions, which again is important. And part of PACS is known as the good behavior game. And what that does, it's part of routine instruction. So again, like I said, it's very important not to make children feel that there's an issue with them, because we are trying to teach them how to allow themselves to discuss their own emotions. So we want to teach more emotional wellness. So being able to integrate this into daily instruction looks a lot different than, you're a disruptive child, you need to go to the school counselor or school psychologist. So next slide, please. And I think that might be the end. Yes.
Yeah, thanks so much, Jill, and thanks to all of our panelists. I appreciate you being with us. We're very short on time, but I did want to get to some questions. Tim, I'm going to go to you first because there's been a lot of questions in the chat about medically assisted treatment. You touched on Suboxone. You talked about the need for therapy and at the same time. Can you expand on that? Can you talk about the value of medically assisted treatment or what your thoughts are on it? Tim, you're muted. I believe you're muted.
Just trying to waste the time we don't have. All right. So as far as
No worries.
medication-assisted therapy goes, yes, I've seen some questions in there. So, generally it's up to the person and in conversation with the doctor how long they're on the medication. Some people want to be off of it quickly. Some people stay on it indefinitely. In the VA, there's no demand in terms of how long you're on that medication, but the VAs are allowed to prescribe buprenorphine, and we also have specific programs that you can go to for treatment if you need more intense treatment. As far as the therapy goes, part of the benefit of therapy is that it helps people stay on the medication if necessary. The people that come off the medication, as we talked about, as Jill was talking about, that have mental health concerns are more likely to end up relapsing. So having the appropriate therapy aligned with that could be really helpful. I did see a question real quick on the NA about medication assisted therapy. NA, as far as we know, still has no opinion on it, right? That's what they say. But they do also say that if you specifically go to a group and you don't like what the people say, because the individuals, they have no control over. So the organization says they don't have an opinion on it per se, right? But you would have to go shop for a meeting that would be more in terms of what you're looking for, because not all of the individuals in those meetings will feel the same way about your medication assisted use.
All right, thanks. And we're out of time, but I just want to go one last quick comment from all our panelists. Jill, I'll start with you. I know you hit on a lot of topics in our schools, in our families. One last comment or point for our attendees today.
I would say that the easiest way to find out if someone is using substances is give your family member a hug. And I know people are like, what? Give them a hug. You can look at their eyes, you can smell them. It's very easy. Do something as simplistic as that. And, just be kind to everyone. You never know what anyone is going through.
Excellent. Thank you. And Tiffany, one last comment for our attendees today.
Thanks, Angela. So thank you for having me. And for us, I think the biggest thing is, to the extent that all of us can play a role in decreasing the silos. So nothing is ever solely mental health, nothing is ever solely substance use disorder, or nothing is solely co-occurring. It's a little bit of everything. And when we break down those silos and we start to work together, I think we can really help the community we're serving.
Absolutely. Thanks so much. And Tim, I'll leave you with the last comment.
I talked about the amount of people in New Jersey that are dying of opioids. These are the people that are dying. There are much more people that are on the opioids now. So they're still alive that are, so these are the people that you're able to get in there, do your PHQ2s, do your primary care PCLs, these are the PTSD screenings, the depression screenings, really find these people in your offices and where you have them so that you can get them the care they need.
Excellent. Great point. Thank you again to all of our expert panelists. Your information was incredibly helpful. And thank you to all of our attendees for joining us today. We have some information on the screen about how you can obtain your continuing education credit, or CMEs. Also information on our next webinar, which is kind of a follow-up to this discussion, because we're going to be talking about trauma and opioid use disorder, We're going to be meeting again on Thursday, April 25th, and I hope that you can join us. So I want to thank you all for joining us today, and be well, everyone.